to do. So thank you for that. We're not going to have questions now. We're going to hold them to the end of the session. So make sure you keep notes. The next presenter is again a group who've been among the most prolific in terms of the work that they've been doing for the centre. Tony Scott from Melbourne University. Tony's going to present on incentivising value-based care through payment models. An extremely important tool or lever in moving the system to where we want it to go. So over to you, Tony.
Thanks, Annette, and thanks for asking me to speak. It's useful to, the issue of overdiagnosis and overtreatment, it's useful to kind of just keep that in our minds as we go through this, because we might want to then say, well, you know, how do financial incentives influence that? And you might think that in volume-based payment systems like fee-for-service or the use of DRGs, they provide financial incentives for people to do more of the good stuff, but also more of the bad stuff. And with that single payment model, you know, with one payment model alone, it's kind of hard to do anything with that. You can change the relativities of fees and payments across different services. So you might think that, you know, well, a fee for a PSA test should be just removed completely, perhaps, or it should be very low compared to more high value tests. So even within fee-for-service, you can think of these payment schedules and the payment relativities of providing incentives to do more or less of one thing or the other. But so that's just an interesting case study kind of to keep in mind as to how we might use payment models to support better healthcare. I guess we've done a number of pieces of research over the last few years, mainly reviews of the literature on using financial incentives to kind of change behaviour. And I'm not going to talk about those in detail, but I just want to kind of go through some issues in payment systems that have been happening in Australia right now, tell you about some kind of innovations in these payment models, and then kind of where to go from there. So within Australia, I guess there's various sectors, various different kinds of healthcare provider within those sectors. And within primary care, we know that doctors are paid largely by fee-for-service. There's practice incentive program payments, which are paid directly to practices, as well as GPs, which are kind of more fixed payments depending on the number of patients that you have. And then there's been some experimentation with mixing fee-for-service with capitation payment and pay for performance. We've had the Diabetes Care Project, which included both capitation and pay for performance. Then Healthcare Homes trial, which just looked at kind of capitation or fixed payment for chronic disease patients only. And also still to be introduced is enrollment for patients over the age of 70, and whether there's going to be some fixed payment associated with that. So there has been some experimentation in trying to change these models of care at the margin to move away from volume-based payment. With hospitals in Australia, we have diagnostic-related groups, which is again a volume-based payment, but essentially hospitals have a fixed budget as well. So you know, if you treat too many patients over the budget, then your payment starts being reduced actually. So that's another way to kind of control the amount of care. And you can even do that in a fee-for-service system. You just have a fixed budget, and once you hit the budget, providers get lower remuneration. That happens in hospitals. Now, one simple thing that I mentioned before with overdiagnosis and low-value care, if you can identify it, is just don't pay for it, and then that at least won't support it happening. It still may happen, but that's what they've done within the hospital sector. Independent Hospital Pricing Authority have started not paying for sentinel events in hospitals. That's errors and mistakes. They've stopped paying for episodes with hospital-acquired complications, and they've stopped paying for episodes with unplanned readmissions. So these are kind of, you know, things that we can measure. They're not directly related to health outcomes, but they may be, but they're kind of at the bottom end of trying to stop bad things happening, essentially. And And then also there's been some experimentation with bundle payments, where essentially you're moving away from DRG volume-based payment, but for a patient, you're giving them a fixed payment, and then the provider can do the most appropriate thing for that patient, which could include treating them outside of hospital in a more appropriate setting. So those bundle payments are being experimented with as well. And then we also have non-GP specialists in Australia, in private practice and other ways, who work between public and private sectors. They pay the salary in the public hospital and charge fee for service in the private sector. And really, they haven't been touched at all in terms of payment models. We don't seem to be worried about them, but I think we should be. And then also there's payment models for other sectors. Aged care, that's a big deal right now. The Aged Care Royal Commission, how should we pay providers? Pay for performance hasn't been mentioned, mainly because quality isn't being measured very well. But once we do measure quality in aged care, residential aged care, should we be paying for performance? So there's those issues coming up as well. So that I just wanted to give a bit of a landscape of what's happening and where things are heading. There hasn't been a lot of large-scale reform here, and so not very much for us to kind of evaluate. But nevertheless, there are important issues in how you develop these systems. One of the issues particularly is information that we need in data and data linkage in order to measure outcomes and quality, to measure adverse events, to measure low-value care. We really don't do that very well. We measure death very well, we measure failure very well, but we don't really measure success. So it's hard to kind of reward for it if we don't measure it. But that's a real precursor to kind of being able to adjust payment systems to support this. Some key payment innovations that have happened in other countries is trying to generally reward for both lower costs and higher quality. Rewarding for quality improvements, pay for performance has been a big deal in the UK and the US, where they can measure quality. The big thing in the UK was the quality and outcomes framework for GPs, where there was hundreds of indicators of performance. GPs, about 30% of GPs' income was depended on that. But that's important, but that ignores cost as well. And value is about both cost and outcomes from a health economist perspective anyway. So there's been other models which are linking shared savings to quality. So this has been implemented in alternative care organizations in the US, where essentially you're measuring quality, but you have a global budget. And if the provider saves some money, comes under budget, then they get the share in the savings. So they have a financial incentive to keep costs down, and the amount of savings that they get depends on their quality. So essentially, if they produce very high quality, they're going to get a much higher share of the savings. So, and that's been shown to have mixed effects, but also in some instances, in some of these kind of closed health systems, if you like, in the US, they've shown to be work. And then also this issue of bundle payments. Bundle payments, one end of the extreme, you have a fee-for-service model like our Medicare, where, you know, if you're having a heart operation, there might be about, you know, a heart bypass, there might be about 15 different fees that can be charged for that one thing, right? And depending on what happens, bundling it is a bit like moving to DRG payment and say, well, if you have a coronary artery bypass graft, it's one payment, that's all you get. And whatever you do within that, it's up to you. So again, bundle payments tend to do that, and they can go broader than just one particular episode. They can move into kind of, you know, paying for the whole care of a whole patient, no matter what happens to them over a year, which is more capitation payment. So this thing of linking quality with a fixed budget and with bundling payments is important, but it all relies on much better data than we have now. So key challenges and issues. Payment models should be supportive of value-based care. They're not the only thing that changes behavior. Obviously, you know, healthcare providers want to help patients and do the best for patients. Very complex payment models aren't really necessary, I don't think, but we need to align what we have with best performance, because I think now there's lots of instances where we know that current payment models don't really support doctors to provide best practice care in their view. And also it's about blended payments. It's about not having just fee for service or capitation, but it's blending them so that for a given episode, there's different payment methods which kind of reduce the strong incentives of either of those. So moving wholly towards capitation for a group of patients, capitation, you know, that provides incentives to do less, not more, which is not good for some patients. Sometimes you still want to do more. So then when you have a bit of a mix of fee for service, which encourages you to do more, but also capitation for some patients where it encourages you to kind of balance those incentives out. As I said, we need good data, preferably at the minute the data we're having are on patient safety events and bad things that happen to try and stop those. But we're still bad at measuring health outcomes. We're still bad at measuring the good things that happen, and linking payments to those is just as important. And we need very good data on risk adjustment for that as well. There's issues about the strength of incentives to reinforce any desired behavior change. Does size matter? Yes. But again, the evidence is not so clear on that. But as a health economist, I would like to think that it does matter. But again, you know, we have to think of what incentives those payments do provide, and also do providers notice. A lot of these payment models for hospitals particularly, or even for practices and big medical groups, the payments have been made to the medical group, and whether those have been filtered down to the providers who are making the decisions is very unclear. Whether providers are able to use that as their own income or to invest in the services, you know, that's a key issue in the salience of these kinds of incentives that come down. There are gaps in evidence still. There's a lot of information and data and studies on payment models. It's mixed as to whether they work in some contexts and not others, depending on what you want to do. We've got very little evidence on the effects on health outcomes specifically. Although we talk about unintended consequences of payment methods, and we can probably all name a few, there's very little evidence on that when you look in the literature. Selection of providers, a lot of payment models are voluntary. So you get the best performing providers selecting into these schemes. And so, you know, we've got to be careful about that as well. And also, you know, we're not sure about what impact this has on access to care for patients, because it may mean that providers are selecting healthier patients to treat and not the patients who are most in need. So there are some issues there. There's literature on this, but it's still unclear as to, you know, what impacts these factors are. So I think overall we need a payment system to better support healthcare providers to do what they do best. And the payment system has to be built on other measures of quality and quality improvement. It's not the only thing, it's not the be on and end all, but it has to at least not divert them from providing good quality of care and that kind of thing. Okay, I'll stop there. Thank you.
Thanks. Thank you very much, Tony. Lots of things to think about there, and I'm sure we'll have lots of questions at the end of our panel. The next person is going to